speaker is a bright young surgeon, Dr. Swati Upadhyay from the famous Arvind Eye Hospital at Pondicherry. Though she's young, she is the pioneer of minimally invasive glaucoma surgery in India and has been the first to perform the various trabecular cutting procedures. And we all wish to learn from her because we are latecomers in the field of MIGS. So I would request Dr. Swati to share her experiences with the trabecular cutting procedures, which are very relevant to countries which don't have a very high per capita income. So over to you, Dr. Swati, please.
Thank you, sir. At the very outset, I would like to thank the organizing committee of International Ophthalmic Conclave 2022, Dr. Tanush Dada, Dr. Namrata Sharma, my mentor, Dr. Venkatesh, and Dr. Chelvin for giving me this opportunity. I would like to share my screen now. I hope my screen is visible, sir.
Yes, yes. Please carry on.
So the big debate is between trabecular bypass devices versus trabecular cutting procedures. And I'm Dr. Swati Upadhyay from Arvind Eye Hospital, Pondicherry, and I'll be speaking on trabecular cutting procedures. I have no financial interests. So the question is whether I should implant an iStent or an iStent inject or iStent W or a Hydrus, or should I do a GAD or a KDB or a bang and a trabectome? So basic area of concern in glaucoma is the trabecular meshwork. So in KDB, we excise or we actually incise the 120 degrees of the trabecular meshwork. In trabectome, we ablate and remove 120 degrees of trabecular meshwork. And in GAD, we open up 270 to 360 degrees of the trabecular meshwork. So what happens when you cut the trabecular meshwork or open it? According to Amari et al., 4 types of histological changes were observed in their study of eyes who had already undergone trabeculotomy when they were undergoing trabeculectomy. So they found either there is a persistence of a disconnected trabecular meshwork with a swelling or degeneration at the cut edge, or fusion of the trabecular meshwork, or a membrane covers the innermost part of the trabecular meshwork, or there are pigmented cell invasion into the disconnected trabecular meshwork at the pass site. All these 4 things look very horrible, and then these make us feel, do they really work? So here's the evidence which I'm going to show. A study done by Lee et al., they compared KDB phaco versus iStent phaco, and they found that they both provided comparable IOP and medication reduction, and the proportion of eyes that were able to discontinue 1 or more medications while maintaining an IOP of less than 18 millimeters of mercury was significantly higher in the eyes undergoing KDB phaco. Now, KDB versus iStent inject, in a study done by Arnold George et al., they have shown that all KDB and iStent subgroups except the standalone iStent inject, they show significantly IOP reduction and as a standalone procedure or combined with cataract surgery. But goniotomy with KDB in this setting seems to offer an advantageous IOP reduction as compared to iStent inject. Coming on to GAD versus iStent inject, study done by Hamza et al. Has shown that 86.4% patients at 1 year in the phaco GAD group met the success criteria compared to only 35.1% in the phaco iStent group. So this study shows that phaco GAD has a significantly higher reduction, and phaco iStent appears to have a higher safety profile in patients who are monoocular or who have a high risk of bleeding. So everybody would think that only open angle glaucomas can be dealt with these trabecular cutting procedures. But a study done by Fontana et al. Have shown that GAD in CACG patients also effectively reduces the IOP and the number of medications with low risk of complications. And they also found that an open angle without pass was achieved in majority of their patients. So why I prefer cutting procedures? Yes, I would agree with Dr. Robert that mild glaucomas can be dealt with implants. But what about patients with moderate to severe glaucomas who have high chances of macular snuff out, or geriatric age patients with systemic comorbidities, and where you can't just keep on adding and stopping and adding medications and then their quality of life is affected, or patients on maximum medical medication with poor compliance and adherence? And what about moderate to severe glaucoma? So as the severity increase, you can't just keep on increasing the number of implants as shown by Dr. Ong. Yes, more implants lead to more IOP drop, but more cost is there to the patient. In a study done by Katz et al., it's a prospective randomized study of 1, 2, or 3 trabecular bypass stents in open angle glaucoma. They showed that there is with each additional stent, significant greater reduction was seen in IOP and medication usage was decreased. So if you implant more implants, eye stents, then more IOP drop will there, but more cost to the patient. And in developing countries like India, eye stent and these implants are the most cost prohibitive things, because one eye stent costs around 69,000 rupees, and a pair of eye stent injects costs around 1.5 lakhs. On the other hand, if you see, if a 125 gauge needle used for bang just costs 75 rupees and it does not need any approval. Similarly, one Prolene suture costs around just 10 US dollars, and also GAT doesn't need an approval, formal approval. The hook dual blade is not yet approved in India, although it costs lesser than an iStent or iStent inject. Trabectome is approved, but it also costs 1,000 US dollars and around 52,000 Indian rupees for one tubing. So cost is a major limiting factor. And these are some low cost alternatives available to us. Second comes availability. We all know that Barwald has been available in the world since 1990, but it is not yet freely available in India, and it took us 23 years to come up with oral or aqueous drainage implant, which was commercially available in 2013. iStent, as Dr. Tanush said, it has just got introduced in India in 2021, and it took the company 3 to 4 years to get entry in the Indian subcontinent, and insurance companies are yet to include these implants in their packages. Now, to the contrast to all these, if you see GAD or a KDB, they are readily available. Prolene is easily available. 25 gauge needle is also easily available. And once you practice these procedures, they really prove to be a boon in combination with phaco. Some universal concerns are hyphema post-GAD. These are the first day post-operative periods of patients. One, the eye on the left-hand side shows microhyphema, and on the right-hand side shows a blood clot in the nasal angle. And there is a study by SP Noza et al. Who have shown that there is a bilateral delayed onset of hyphema after following pupillary dilatation in patients after GAD surgery. So they say that ophthalmologists should be aware of the possibility of microhyphema after induced mydriasis. But I would say that 90% of the hyphemas on first postoperative day resolve within first week, and late hyphemas are very rare. Now, another concern is, if you remove the trabecular meshwork, where will the anti-glaucoma medication act? The newer medications like rho kinase inhibitors and norepinephrine transporter inhibitors, they enhance the conventional outflow, which is the trabecular meshwork. Latanoprost and Bunod and trabecular they also act on the uvascular outflow and the trabecular meshwork outflow. But my defense in favor of trabecular meshwork cutting procedures is that KDB and BANG, we only remove 4 to 5 clock hours of trabecular meshwork. So rest 7 to 8 clock hours is still available for the AGM to act. In GAT, we incise 270 to 360 degrees of trabecular meshwork, but trabecular meshwork still remains, and over a period of time, the inferior and temporal leaflets of the angles fuse again. So we still have 180 degrees of trabecular meshwork still available for the AGM to act. Now, peripheral antevenous synechiae after trabecular meshwork cutting procedures, they do happen, but not in all cases. And if they occur also, they are very small based and they are not extensive. They don't cross. They don't go into an extensive pass or closure of the angle altogether. They don't occlude the cleft. As you can see on the right hand side image, the white cleft is beautifully visible after doing the suture GAT. And as I have shown earlier, Fontana et al. Have shown that GAT in CACG works very well and the angles remain open without pass. Another major concern is most of the studies done so far are retrospective studies and not mostly done in Indian eyes or in developing world, and long-term follow-up results are still lacking. And we have compared iStent with phaco, KDB with phaco, but the comparison with the gold standard trabeculectomy needs to be done as a randomized control trial in our scenario. So my take-home message will be, GAT is a safe and effective procedure in treating various forms of open-angle glaucoma, like primary open-angle glaucoma, steroid-induced glaucoma, uveitic glaucoma, failed trap, and also some cases of angle closure glaucoma. BANG and KDB are safe and effective option for monocular and advanced glaucoma. Implants look very fancy. Yes, they are. They work, but they are cost prohibitive with lesser IOP control than GAT or KDB. And we need robust randomized control trials to prove long-term efficacy of all the mixed procedures. In the end, I would like to end my talk by quoting our Honorable Prime Minister's Mr. Narendra Modi's quote: "We must ensure that technology is accessible, affordable, and adds value." Thank you so much.